What's going on, everyone? My name is Derek Hess. I'm an MLS student, phlebotomist, and aspiring physician. Chances are, at some point in time, you're going to need some lab work done. So today, we're going to walk through a properly performed blood draw, give you basic medical knowledge that every patient should know, and address some frequently asked questions that I think deserve some answers. So let's jump right into it. First things first, verification. The last thing that we want to do is needlessly poke somebody and send a mislabeled specimen to the lab. Next, it's time to palpate, which is a medically sophisticated way of saying feel. We're trying to locate a vein. Quick note regarding tourniquet time. It really shouldn't be on for over a minute because it can cause this thing called hemoconcentration, which is basically the vein recognizes that it's being constricted, and so smaller molecules diffuse out of the vein wall, leaving behind larger ones like cholesterol, falsely elevating results. The first spot that a phlebotomist is trained to look is right here in the crease of the elbow, otherwise known as the antecubital fossa. There's three main veins that they're looking for, and the first is the median cubital vein, found near the center of the fossa, and then the cephalic vein, which can be found on the radial or thumb side of the arm, followed by the basilic, which can be found on the medial or pinky side of the arm. Now that we know where we're going and who we're poking, we can put on our gloves, tie the tourniquet, and disinfect the area in preparation for the draw. Next, we firmly anchor the vein, insert the needle, and begin filling tubes immediately. Then we pop the tourniquet, invert our tube, and grab a piece of gauze to cover the puncture site while we remove the needle, activate the safety, and hold for about 30 seconds. After we've made sure our patient is done bleeding, we quarter the gauze so that the cleanest part makes contact with the puncture site. We tape it in place, label the specimen, bag it, and send it off to the lab. Now for some frequently asked questions. Right here we have our arm, our super realistically drawn vein, and our tourniquet. When you tie the tourniquet, this compresses the veins. That causes the blood to back up inside of the vein. As it backs up, it begins to expand the vein walls and causes them to swell. This makes it an easier target for the phlebotomist. This is obviously going to have a little bit of variance, but one of the more frequent examples that I can think of are going to be repeat tests like hemograms that are taken in these purple tubes, otherwise known as a complete blood count. These might be taken every day, sometimes even multiple times a day. Reason being is that the body is constantly changing, so having the most accurate and up-to-date results helps the doctor point you in the direction towards recovery. Another pretty common scenario that I can think of is in the emergency room. They might draw something called a rainbow, which is pretty much just an assortment of tubes. And the reason that they do this is because each tube has a different additive. Each additive is for a different test. So if the doctor decides at a later time that they want to add more tests on, you don't have to get repoked, and the results come back quicker because the lab already has your blood. It's a win-win. The last thing that I can think of are blood cultures. In a normal vial, you only need 3 to 5 milliliters, and in a blood culture bottle, you need 8 to 10. There's also 2 of them, aerobic and anaerobic. That's roughly 5 times the collection volume. So I understand why there's some apprehension, but you have to understand that sepsis is a bacteria that lives in your blood, and if left untreated, can kill you. 8 to 10 milliliters is necessary because inside this bottle, you'll find a broth, which acts as food for the bacteria. 8 to 10 milliliters of blood, if the bacteria is present, gives it a dense enough population to reproduce inside this bottle that it can be detected by the analyzer. Like I said, I understand the negative feelings surrounding it, but when you understand that the other option is dying, then maybe losing a little bit of blood today that your body will replace in the very near future isn't such a bad trade-off after all. That's all I got, guys. Thank you for watching. I hope you learned something. And remember, patient advocacy isn't just speaking up for yourself. It's about partnering with your provider to become an active part in your own care. Stay curious, stay happy, and stay healthy.